Can start, sir?
Yeah, okay.
Today our topic is EACTS guidelines for diagnosing and treating acute and chronic syndromes of aortic organ. The perception of aorta as an organ in its own right is a recent development. This transformative perspective was first captured in a pioneering document about the vessel aorta by Raymond Herbel for the European Society of Cardiology in 2001. The scientific community has recently realized the unique function of the organ aorta. They have come to understand its critical importance, necessitating on updating update of our current knowledge on its physiology and pathophysiology. Pathophysiology and natural disease course of the aortic organ. It is recommended to view, interpret, and treat the aorta in the context of an organ, whereby diagnosing, treatment, and
Can
surveillance
you
is
can
the
you
approach.
speak a bit louder?
Yes, there is no better description of the aortic organ than the universal definition of an organ being part of an organism which is typically self-contained and has a specific vital function. In other words, a functional unity. It is recommended to view, interpret, and treat the aorta in the context of an organ, whereby diagnosis, treatment, and surveillance should be approached with this perspective. The development of the aorta and the mechanism of aortic diseases includes the aorta exhibits a heterogeneous developmental origin. The aortic root is derived from the cells of the secondary heart field, and the ascending aorta part and part of the aortic arch stem from the neural crest, and the most distal part of the aorta is of the mesenchymal origin. Most congenital anomalies of the great vessels are the result of either persistence of the segment that normally regresses or vice versa. The vascular smooth muscle cells are the predominant cell population in aortic tissue and interact with the extracellular matrix in maintaining the aortic hemostasis. This is the diagrammatic representation of the origin and microstructure of the aorta. The aortic root part, which is shown by the red color, is derived from the secondary heart fields, and the ascending aorta and a part of the aortic arch is derived from the neuroclast, and the rest of the aorta is derived from the proximal mesoderm, paraxial mesoderm. And the right side picture depicts the layers microstructure of the aorta with the innermost intima consisting of endothelium and internal elastic membrane, and media consisting of smooth muscle cell layer along with elastic lamellae, and the adventitia consisting of external elastic membrane, vasa vasorum, and nervi vasorum. Different models of aortic disease describes changes that lead to the loss of contractile function of the smooth muscles and a phenotypic switch towards similar cells of different origin, such as mesenchymal cells or myofibroblast. The decreased expression of these smooth muscle cells, proteins, and increased expression of inflammatory proteins such as matrix metalloproteinases have been described in the context of thoracic aortic diseases. Fibrillin 1 is an important component of the extracellular matrix and plays a key role in transducing mechanical stress between the extracellular matrix and the vascular smooth muscle cells. Variants in gene associated with transforming growth factor beta signaling pathway have been implicated in aneurysm formation in the context of heritable connective tissue disorders with Marfan's and Louis Diaz syndrome being the most prominent ones. TGF beta is an ubiquitous cytokine in most mammalian cells that controls proliferation and cell differentiation. Several TGF beta associated vasculopathies have been identified and have turned the TGF beta signaling pathway into a promising target for therapeutic interventions. Coming to the epidemiology, an aortic aneurysm is defined as 1.5 folds increase to its normal vessel diameter for the descending and abdominal aortic aneurysm, and more than 45 mm for the aortic root and the ascending aorta. The aortic dilation in the aortic root and ascending aorta is defined as diameters ranging from 40 to 45 mm. Data on the epidemiology of acute aortic syndromes are limited. In autopsy studies, the prevalence of aortic dissection ranges from 0.2 to 0.8%, whereas in most population series, the incidence of aortic dissection ranges from 0.61 to 7.2% per thousand per lakh people. Data on the epidemiology of the abdominal aortic aneurysm are less scarce, not only because of the ease of diagnosis using abdominal echography, but also because of several national population screening studies. Overall, the prevalence of abdominal aortic aneurysm is decreasing, whereas population studies and screening trials in the late 20th century reported a prevalence of 4 to 5% in men. Most studies report lower rates, often used to counter-argue national screening plans. How to speak a common language? The need to use a common language in aortic medicine is growing, the main reasons being aortic medicine is now a subspecialty in which the aorta is viewed more and more as a complex organ and not simply as a large vessel distributing blood. The patients with aortic disease are followed lifelong, with many requiring several aortic interventions over time, and a common language facilitates long-term follow-up and reporting of results. Aortic medicine is multidisciplinary, so a common language is essential for effective communication among vast array of specialties, including cardiovascular surgery, cardiology, radiology, anesthesiology, rheumatology, genetics, and endocrinology. The categorization of tears in aortic dissection. The writing committee suggests that the term multiple entries and re-entries be removed from the clinical use and be replaced by the wordings most proximal term tear, communications between lumina and the most distal tear, in addition to the term primary entry tear. This proposed wording should help create a better understanding of the pathophysiology as well as help standardize communication among physicians describing the pathological categories. Coming to the aortic arch replacement of various extents. When referring to aortic arch treatment, qualitative and semi-quantitative statements should be avoided. Due to the rising number of patients receiving open and endovascular therapy, it seems reasonable to refer to the treatment-based classification using the terminology of zones 0 to 4. When describing surgeries of the aortic arch, the residual dissection after a type A repair. The chronic dissected state of the aortic segment distal to the proximal repair is defined as residual dissection after type A repair. The writing committee uses the term parallel grafts to refer to chimneys, snorkels, and periscopes. A hybrid approach is the combination of an open vascular surgical technique and an
Slide
endovascular
not moving.
procedure, yes, performed by simultaneously on a sequential basis of to treat the aortic diseases. Coming to the acute aortic dissection, the location of the primary entry tear, the extent of the aortic valve dissection determine both the pathoanatomic classification and essentially the treatment strategy. A proximal or a type A aortic dissection involves the ascending segment of the aorta and requires open surgery in almost every patient, whereas type B aortic dissection excludes the ascending aorta and could be managed medically in combination with endovascular interventions in many patients. Improving diagnostic and imaging quality recently identified a subgroup of non-A, non-B dissections with a separation of medial layers encompassing the aortic but sparing the ascending aorta, with an entry tear often found in the region between brachiocephalic and left subclavian arteries. This is the type classification of the aortic dissection. In type A, the ascending aorta is involved. In the type B, ascending aorta is not involved. And the non-A, non-B dissection, where the arch is involved but the ascending aorta is left. A type A aortic dissection consists of 59 to 60% of all aortic cases. A type B dissection accounts for around 31% and a non-A, non-B dissection for 3 to 10%, with minority showing an entry tear located not in the arch region but rather in the descending aorta with retrograde propagation of the false lumen into the arch. The aortic dissection is further subclassified based on symptoms of dissection onset as acute, subacute, and chronic. Acute being within 14 days after dissection onset, and subacute being between 15 to 90 days, and chronic being more than 90 days. The extent of the disease by Ishimaru zones. The aorta is divided into the following zones: the aortic root, ascending aorta, arch, descending thoracic, and the abdominal aorta. Ishimaru zones have enabled a more detailed classification of the aortic segments by dividing the aorta into 12 zones, starting from 0 to 11, which is showing in this diagram. This zone 0 being the ascending aortic part, and zone 1 near the left common carotid, and zone 2 involving the left subclavian, and zone 3 2 centimeters from the zone 2, and zone 4 till the T6 vertebrae, and zone 5 just at the from T6 to the level of diaphragm, and zone 6 near the celiac, and the zone 7 involving the area which gives rise to the superior mesenteric, and zone 9 being the pararenal, zone 8, and zone 9 being the infrarenal area, zone 10 being the common iliac, and zone 11 being the branches external and interiliac. They recommend They recommend referring to the types 1, 2, and 3 aortic arch configurations when reporting on the aortic arch anatomy. Well, in which the type 1 aortic arch, all the supra-aortic branches origin are at the same horizontal level. In type 2, the innominate artery originates between the horizontal planes of the outer and inner curvature of the aortic arch. And if the innominate artery originates below the horizontal line of the inner curvature of the aortic arch, it is a type 3 aortic arch, which is shown in this diagram, where the first one is type 1 in all the levels, like all the branches are coming from the same level. And the type 2, the innominate artery is arising in between the outer and inner curvature. In the type 3, it is coming below the inner curvature. The acute type A aortic dissection is a critical surgical emergency that necessitates immediate intervention in most cases. Despite significant advancements in surgical techniques and perioperative management, the repair of type A dissection remains associated with substantial mortality and morbidity, with reported mortality rates exceeding 20%, depending on the presenting characteristics and operator experience. Risk stratification provides a simple and reproducible methods for risk-adjusted outcome assessed for quality improvement. There are two risk assessment methods are currently used in type A dissection. Those are the German Registry for Acute Aortic Dissection type A score and the Penn classification. The Girarda score is calculated using a web-based application and stratifies patients into low risk in which mortality is less than 15%, and intermediate risk in between 15 to 30%, and high risk patients where the mortality is more than 30%. The input in this Gerarda score includes age, sex, resuscitation before surgery, any history of previous cardiac surgery, or intubation before surgery or at the time of admission, or any use of catecholamine support at the referral, or grade of aortic regurgitation, and any organ malperfusion or hemiparesis or extension of the aortic dissection in the location of the primary tear. The Gerarda score can effectively predict the 30-day mortality rate and has been validated in various cohorts, although it may overestimate overall risk in some populations. The Penn classification is a very parsimonious categorization of patients based on the total body burden of ischemia, with classification ranging from none, Penn class A, to local or regional ischemia in Penn class B, global ischemia or shock in case of Penn class C, or combined local and global ischemia being in Penn class BC. The system has been validated and emphasizes total physiological ischemic burden and considers hemodynamic collapse in the absence of localized ischemia. The European update of the Stanford classification, the type entry malperfusion classification (TEM) classification, has been recently proposed. In the TEM classification dissection, the type T is defined by the dissection extent as proposed by the Stanford classification and not by the entry location. The type, it gives information on the location of the primary tear by E and the malperfusion status by M. The entry location 0 is given if the primary tear is not visible, 1 if it is in the ascending aorta, 2 if it is in the arch, 3 if it is in the descending aorta as E0, 1, 2 and 3. Malperfusion status is noted by a 0 if the malperfusion is absent, 1 if it is seen in the coronary arteries, if the coronary arteries are affected, 2 if the supraortic vessels are dissected, 3 if the visceral or renal or lower extremities are affected. A plus is added if the malperfusion is clinically present, and minus if it is clinically absent but radiologically seen. This diagram represents this TEM classification where type A, type B, and non-type B, where the extent is seen in this T classification, and in E 0, 1, 2, 3, where 0 the entry tear is not seen, 1 ascending aorta is seen, 2 in the arch, 3 in the descending. And M shows the malperfusion with M0 no perfusion, M1 in the coronaries, M2 in the supraortic, M3 in the distal. Coming to the bicuspid aortic valve aortopathy, the aortopathy associated by bicuspid aortic valve has in the past been the object of intense scientific debate, especially concerning its pathogenesis, whether it is genetically determined or hemodynamically driven. Most recently, a large group of international experts developed a consensus statement on nomenclature and classification of bicuspid aortic valve and the associated aortopathy. The valves should be described as fused or two sinuses or partial fusion type, whereas the aortopathy has been classified as root type, in which 15 to 20% cases dilatation prevailing at the level of the sinuses, and the ascending type, which is seen in 70 to 75%, where the dilatation is more in the tubular part or the ascending part area, or her extended phenotype, which is seen in 5 to 10%, either the root with significant extension into tubular or tubular dilatation involving also the proximal arch is seen. The root phenotype has an association with faster growth of the ascending diameter, the higher prevalence of aortic dilatation in relatives, the greater risk of acute aortic events in post-aortic valve replacement follow-up, the higher propensity to dissect, and potentially aortopathy-related gene variants. Patient with clinical characteristics of root phenotype or the root extended should undergo stricter surveillance and an earlier operation. These pictures gives the phenotype of root and ascending aortic morphology in bicuspid aortic valves, wherein the left side shows the root phenotype, which is possibly eval- evolving into root extended phenotype, where the aortic root is dilated. Gradually, the tubular part of the aorta gets dilated subsequently if not treated. The patients in this category, the patients are more likely to be younger and likely to be taller and male. The dilatation of the sinus of Valsalva and aortic regurgitation often in parallel. Presence in right-left cusp fusion, rare with right coronary, non-coronary cusp fusion. And in the right side, showing the ascending phenotype, where possibility evolves into ascending extended phenotype, where the ascending aorta is tubular part of the aorta is involved, which extend into the proximal arch. These patients are more likely to be older and the pathology not limited to either sex, associated with aortic stenosis and hypertension, present in right-left cusp fusion and right with non-coronary cusp fusion. The aortic teams, the members of the team may vary depending on the type of the center and the institutional resources. Although the patient with aortic diseases can be initially evaluated at every layer of the healthcare system, the core members of the aortic team should include cardiovascular surgeons, cardiologists, and radiologists because all have relevant roles in the treatment of aortic diseases. Moreover, for the routine practical approach, the patient and for specific clinical questions, anesthesiologist, perfusionist, critical care specialist, genetic counselors, neurologist, pulmonologist, renal specialist, specialized nurses and social workers should also be considered as a part of the aortic team. The diagnostic workup for an acute aortic syndromes. These include the diagnostic workup to confirm or to rule out the aortic disease is highly dependent on the prior risk of this condition, which can be stratified into three groups of variables using aortic dissection detection risk score. The predisposing factors like Marfan syndrome or pain characteristics like chest pain, back or abdominal pain, and the high risk clinical examination features like perfusion deficit or new aortic insufficiency murmur. The first line examination includes ECG, chest X-ray, and transthoracic echocardiography and biomarkers is performed primarily in the patients with chest pain in the emergency to, and can be useful to rule out any alternate diagnosis like MI or pericarditis. In case of transthoracic echocardiography, point to the diagnosis of aortic dissection by detecting an aortic intimal flap or aortic valve thickening or dilatation, and major aortic valve regurgitation with or without cusp prolapse, as well as pericardial effusion can be seen. Especially when inconclusive, the transthoracic echocardiography can be finished by looking at the abdominal aorta, which may be helpful to detect a flap not visualized at the thoracic level. A CT scan of the entire aorta is the mainstay imaging technique for confirmation, except when the patient is highly unstable and intubated. Transesophageal echo can be a reasonable alternative for patients under sedation in the ICU to make the diagnosis if the TTE is inconclusive. Coming to the clinical risk assessment, risk stratification of patients is crucial for identifying appropriate candidates for specific aortic procedure. The frailty is one of the most important elements not routinely included in risk models. Several risk scores are available, whereas age, body mass index, preoperative anemia, and hypoalbuminemia have also been recognized indicators of frailty. The daily activities and weight loss could provide additional information about the overall health of the patient. Assessing Baseline neurological function is also important for the initial risk stratification, and a systematic cognitive assessment by experts should be part of the evaluation. A previous stroke can contribute significantly to the neurological morbidity of the patient. A preoperative workup that includes PFT may be beneficial, and blood workup, including the kidney function and liver function test, is necessary for patients undergoing any elective aortic procedure. Peripheral vascular diseases and prior interventions, including radiation therapy, are important determinants of the clinical outcome of the surgery. Coronary artery disease and cardiac function are crucial in patients who undergo elective cardiac and aortic intervention. Coming to the imaging, compute, computed tomography as a minimum standard for imaging of the aorta, an isotropic resolution of 1 mm should be available in the CT scanner system used. For the imaging, the aortic root and the ascending aorta, ECG triggered or fast acquisition techniques are recommended to minimize the pulsation artifacts and increase the measurement accuracy and diagnostic reliability. The use of an intravenous iodine-based contrast agent is suggested for most aortic imaging because it allows delineation of the aortic lumen and improves the assessment of the aortic wall changes. The CT has a very high sensitivity and specificity, including in aortic dissections, intramural hematomas, and traumatic aortic lesions, as well as aneurysms and silent dissections. In addition, CT can detect concomitant coronary artery and or branch vessel involvement, as well as the pericardial involvement, and help identify entry tears. A contrast-enhanced aortic phase series extended from the thoracic inlet to the level of the femoral artery is recommended in most cases. MRI MRI is the only other modality besides CT that can provide 3D images with sufficient temporal or spatial resolution and anatomical coverage of the aorta to determine the vessel enlargement and vessel wall changes. Due to its better soft tissue contrast, MRI is preferred modality to characterize aortic wall changes associated with inflammation. An MRI but does not require ionizing radiation, but the limitations of the MRI include the occurrence of the artifact in patients with stents and other metallic implants or devices. And in addition, it has lower it has much longer acquisition time and lower spatial resolution compared to the CT. Further, MRI has a limited ability to monitor and treat unstable patients in the scanner. Gadolinium-based intravenous contrast agent can be used to enhance the MRI and are often used for MR angiography. Gadolinium-based IV contrast agents carry some risk for nephrogenic systemic fibrosis in patients with impaired renal function, so it should be avoided in those patients. Coming to the transthoracic echocardiography, TTE is the most commonly used imaging modality for the initial examination of the thoracic aorta. It is particularly useful for visualizing the aortic root, ascending aorta, as well as for assessing the anatomy and function of the aortic valve. Although TT is not ideal for imaging the aortic arch, it can often visualize the vascular branches of the aortic arch and proximal descending aorta, and can aid in the diagnosis of coarctation of aorta and ductus arteriosus. It is useful in the evaluation of complications such as aortic regurgitation, LV dysfunction, and cardiac tamponade. Transesophageal echocardiography provides high-resolution images of the most of the thoracic aorta, except for a small segment of the ascending aorta distally due to acoustic shadowing of the trachea. It is also useful for a detailed understanding of the aortic valve anatomy and function, and is particularly useful in the intraoperative evaluation of patients to guide the surgical and endovascular repair strategies and to assess the true and false lumens before and immediately after the aortic repair. Ultrasound of the abdominal aorta is recommended for screening and monitoring of an abdominal aortic aneurysm, which is defined as more than 30 mm in diameter. usually primarily an anti-AP diameter using the outer edge to outer edge measurements. Although it is an ineffective imaging modality with high diagnostic accuracy for detecting aneurysm, inter-observer variability exists and accuracy can be limited by obesity and intestinal gas overlay. Photon counting CT is emerging in clinical service and is a technology with the potential to overcome major limitations of the current CT scanners, improving and expanding the clinical applicability of the CT imaging. It uses new energy resolving X-ray detectors, counting the number of incoming photons and measuring the photon energy. This technique results in CT data at a higher spatial resolution without electronic noise and with improved image contrast. Moreover, it can reduce the radiation exposure and reduce the artifacts. Coming to the acute aortic syndrome, a type A aortic dissection, uh, it occurs when an intimal tear is propagating the blood flow into the media, resulting in separation of the aortic wall layers by an intimal flap. The propagation of this process forms a true and a false lumen with or without communicating re-entries into the true lumen. The type A dissection refers to those starting in the ascending aorta. The natural course of the disease is very aggressive due to sequelae varying from organ malperfusion to acute heart failure to aortic rupture. The D-dimer blood test is extremely helpful in the emergency setting. If the D-dimer is negative, the patient does not have any aortic dissection. As the D-dimer while has a very sensitive, is not however at all specific, it can rule out but not definitely rule in a dissection. If treated conservatively without surgery, acute type A dissection is associated with an early mortality of 0.5% per hour. The surgery has proven clear benefits over the medical therapy in case of acute type A aortic dissection. Coming to the preoperative evaluation, any and all branch vessels of the aorta are potentially vulnerable to malperfusion consequent to the type A aortic dissection. The false lumen expansion due to hematoma or thrombosis can lead to static obstruction of the true lumen of the aortic branches. In addition, dynamic obstruction of the aortic vessel can lead to low flow phenomena and subsequent malperfusion. So the preoperative malperfusion syndrome is associated with high perioperative mortality up to 4 to 3%, gradually increasing with the number of organs being malperfused. So in the presence of femoral pulses assures that blood is flowing down the entire length of the aorta. Clinical assessment must not be forgotten or neglected in the current high-tech imaging climate. Especially on CT imaging, the true lumen may be reduced to a small size, but if the femoral pulses are preserved, blood is flowing despite the small true lumen. A revascularization first approach using endovascular fenestration or stenting is associated with lower in-hospital mortality and may be considered in patients with radiographic and clinical evidence of mesenteric malperfusion. But many individual surgeons are strongly in favor of immediate replacement of the ascending aorta, which usually but not always correct the intestinal malperfusion. But a growing minority favor the intestinal reperfusion first approach. There is no right or wrong answer to this. Therefore, addressing visceral malperfusion by endovascular first approach can be justified in hemodynamically stable patients. Coming to surgical management, the type A dissection will benefit from urgent surgical repair with resection of the proximal pathology and primary tear area. Due to the unpredictable behavior of the descending dissected aorta, swift repair is warranted, considering a mortality risk of 0.5% per hour while waiting for surgery. In patients undergoing surgical aortic repair, the axillary artery should be used for the arterial inflow and lower body hypothermic circulation arrest in the combination with antegrade cerebral perfusion and an open distal anastomosis obtains favorable outcomes. The combination of these three concepts of axillary perfusion, circulatory arrest with cerebral perfusion, and evaluation treatment of the descending aorta enhancing, enhances the true lumen perfusion, encourages thrombosis of the false lumen. This is the algorithm for the treatment of the acute type aortic dissection, in which type TM type A E0, where emergent ascending and hemiarch replacement is required, and in type A E1, where the ascending aorta is involved, emergent ascending aorta and hemiarch is replacement to be done, and in type 2, where the arch is involved, entry at the if the entry at the outer curvature, emergent frozen elephant trunk is to be done. If the entry is not at the outer curvature, then emergent ascending aorta and hemiarch replacement to be done. And in type A, E3, where the tear is at the distal arch or descending aorta, the entry within the 10 centimeter distal to the left subclavian artery, if it is there, emergent frozen elephant trunk to be done. And if it is beyond that, emergent ascend, not that, emergent ascending aorta and hemiarch replacement to be done. In case of non-A and non-B aortic dissection, currently available outcomes data on the subset of non-A non-B dissection are scarce. Early reports seem to favor open surgical resection of the entry tear and the arch analog to the management of type A dissection, with the idea to depressurize and exclude the false lumen from proximal inflow and subsequent expansion under systolic pressure head. Conversely, medically managed patients tend to reveal progressive enlargement, rupture, or need for a late extensive replacement surgery. This is the algorithm in case of non-A, non-B type aortic dissections, wherein if it is in E0, op- optimal medical treatment followed by regular imaging to be done in E0, and in E1, in high-risk patients, urgent frozen elephant trunk after medical stabilization, and in case of complicated dissection, emergent frozen elephant trunk to be done. And in case of type E3, in non-high risk features, regular follow-up to be done. And in case of complicated dissection, where the ascending aorta is less than 4.5 centimeters and anatomical suitable for TAVR, it should be done. If it is not possible or the ascending aorta is more than 4.5, frozen elephant trunk to be done. In case of type B aortic dissections, which accounts for 30 to 38% of all dissection, several risk factors are known to have the potential to destabilize the course of the dissection and with subacute and late complications. A proximal entry tear with a defect dimension of 10 or more or less, more than or equal to 10 mm, and a high systolic antegrade flow volume in the false lumen with significant diastolic retrograde flow assessed by MRI is a predictor for rapid aortic growth and or even rupture. An initial descending aorta diameter of more than 40 mm and a false lumen of more than 22 mm are risk factors for aortic diameter increase and aneurysm formation. In acute complicated type B aortic dissection with aortic rupture or malperfusion, TAVR has proven beneficial over medical therapy and open descending aorta replacement. The endovascular repair can cover the primary tear, control the rupture in a timely fashion, but it can also restore the true lumen flow and eventually improve remodeling. Due to its favorable outcome, TAVR has emerged as a first-line treatment in patients with acute complicated type B dissection. In patients with unsuitable anatomy for endovascular repair, open surgery using the frozen infant technique or open descending replacement remains an option in highly experienced centers. This is the algorithm in case of acute type B dissection, where the patients without high risk features, the optimized medical treatment and regular imaging follow up to be done. In case with high risk features for the development of complicated dissection, where the ascending aorta is less than 4.5 and it is anatomically suited for TAVR, TAVR should be done within 3 months. Or if the ascending aorta is more than 4.5 or not suitable for TAVR, medical treatment with frozen elephant trunk within 3 months to be done. Uh, in case of complicated aortic type B dissections, where the ascending aorta is less than 4.5 centimeters and suitable for TAVR should be done emergently. In case of ascending aorta is more than 4.5 and not suitable for TAVR, emergent frozen elephant trunk should be done in these cases. Coming to the intramural hematoma, it is characterized by localized hemorrhage within the aortic wall of more than 5 mm and may occur with or without the intimal disruption. The rupture of the vasa vasorum or trauma are considered as the leading pathomechanism of intramural hematoma. Based on improving imaging technologies with high resolution CT, and clinical experience, there is growing evidence that localized intimal disruption, classified as an ulcer-like projection, may cause intramural hematoma over time as the initial intimal disruption occurs progressively. These ulcer-like projections can be detected as a focal contrast enhancement within the intramural hematoma and have communication with the aortic lumen without any evidence of atherosclerosis or local calcification. There are three types. In case of type A intramural hematoma, acute type A intramural hematoma can represent as a life-threatening condition due to the propagation of the hematoma within the aortic wall. Aortic events within the first 7 days are frequent. The aortic type A intramural hematoma, which involves the ascending aorta, evolves into the type A aortic dissection in 30 to 40% or even to rupture up to 18% of hospital admissions. In the presence of complications such as malperfusion, rupture, urgent surgery is recommended equal to that for type A aortic dissection. Given the high mortality of patients presenting with high risk features, emergency surgical repair is superior to medical therapy alone. In patients with ascending aorta diameter of the less than 50 mm and intramural hematoma thickness of less than 10 mm, TAVR was associated with a 5-year survival rate of 98%. There is a high risk features of the intramural hematoma, wherein age of more than 70 years, initial aortic diameter of more than 45, and mean aortic diameter growth of more than 5 mm per year, and wall thickness of involved segment of more than 10 mm, and pleural effusion based on Hounsfield units. Presence of aortic ulcer-like projections are the high risk features of intramural hematoma, where early surgical correction to be done. In type B intramural hematoma, the natural course is more benign than an intramural located in the ascending aorta. In patients with acute complicated type B intramural hematoma, urgent aortic repair is indicated. Open surgical repair has been replaced by TAVR in most cases due to its lower perioperative mortality and morbidity. In the absence of complications, medical management recommended in the initial phase, similar to type A. Evaluation of high risk features for malignant progression of the disease is of utmost importance. Coming to penetrating atherosclerotic ulcer, these are defined as atherosclerotic lesions within the aortic wall originating from the intima and progressing into the media. The clinical presentation and the anatomical features guide the way towards different treatment strategies. Most are asymptomatic and are detected as incidental findings during imaging for other indications. They are located predominantly in the descending aorta. Here is the picture showing the penetrating erythematous ulcer where there is a breach in the intima and the hematoma is going into the aortic wall. Due to the ulcerative and degenerative nature of the disease, PAU can be associated with localized intramural hematoma and carry a high risk of progression into dissection or rupture, especially if located in the ascending aorta. Therefore, symptomatic PAUs are with penetrating erythematous ulcers with high risk features located in the ascending aorta should undergo urgent surgical repair. In PAUs distal to the zone 0, aortic repair should be performed. They were emergent as the first-line therapy in patients with high-risk PAUs in the descending aorta, but is limited to its specific anatomical features. In patients with anatomy unsuitable for conventional TAVR located in the aortic arch, the frozen elephant trunk position is procedure is treatment is the treatment alternative. Coming to the traumatic aortic injury, it is usually occurs at the level of the aortic isthmus, less frequently at the other areas. It is typically affects the young males and is associated with high mortality rates before the patient reaches the hospital. The blunt traumatic aortic injury involving the ascending aorta or the arch is rare and should be treated based on the individual decision making of the aortic team. It is classified into four grades. Grade 1, where the intimal tears. Grade 2, intramural hematoma. Grade 3, pseudoaneurysm. Grade 4, the free rupture. Symptoms vary from completely asymptomatic or non-specific pain to hemorrhagic shock depending on the severity of the lesion. A diagnosis, however, needs to be confirmed on a contrast-enhanced CT arterography imaging. The blunt traumatic aortic injury management is dependent on lesion severity and thus on the BTA grading system. Thoracic endovascular aortic repair is the first choice if treatment is indicated and in the presence of suitable anatomy. Grade 1 lesions can be managed in a non-operative manner by maintaining the systolic blood pressure of less than 100 millimeters of mercury and heart rate of less than 100 with close follow-up imaging. In case of grade 2, lesions include both those with or without high-risk imaging features, which consists of high-risk imaging features consist of posterior mediastinal hematoma of more than 10 mm and lesion to normal diameter ratio of more than 1.4, mediastinal hematoma causing mass effect in case of pseudocoarctation of the aorta, left hemothorax, ascending aorta, arch, and great vessel involvement or aortic arch hematoma. For grade 2 lesions with high-risk features, TAVR is reasonable in the presence of anatomy, whereas non-operative management may be preferred in those without. Grade 3 and 4 lesions should be managed operatively with TAVR. This picture shows the grades of the traumatic aortic injury, where in the grade 1 there is only intimal tear. In the grade 2, there is intramural hematoma leading into the aortic wall. And in grade 3, there is a pseudoaneurysm. Blood leaks through the inner wall but is contained by the adventitia. And in grade 4, there is complete rupture of the aortic valve. Chronic dilatative aortic disease of the root and the ascending aorta. Among aneurysms of the thoracic aorta, those involving the root and tubular ascending aorta.
I think the chronic disease you can speak in another class because we are already exceeded almost an hour.
Okay, sir.
Is there a lot of slides on this?
Yes, sir.
You have to describe everything: ascending, arch, descending. So
Yes,
I think you do this chronic dissection as a separate.
separate. Okay, sir.
Yeah.
Okay.
Fine. So basically, what I want to say is, in the acute aortic syndrome that you said,
Yes, sir.
you should not forget the intramural hematoma and the ulceration because that is not very easily detected or diagnosed, and there is not much of experience on treating that as it is. So many a time, this dissection, the intramural hematoma and ulcers are missed in the diagnosis.
Yes.
Of course, the other thing is the acute dissection, which becomes more or less like a surgical emergency. And I am of the opinion that any patient who reaches the hospital, come what may, whatever his condition is, either post-traumatic rupture or acute dissection, if he's able to reach the hospital, that means he should be salvaged. Because the process of natural selection is already done. If somebody has a very severe disease, he's usually dead even before reaching the hospital. If a patient reaches the hospital, that means you must go all out to try and stabilize him and then to the appropriate treatment. So that is whatever cause this thing may be. It could be trauma, it could be just hypertensive crisis with acute dissection, or hematomas and ulcerations. So you must be all out and then try and do an aggressive management, right?
Yes.
The one curious question I've asked, I'm going to ask you: why is it called frozen elephant ring? What is frozen about it? Anybody? Oh, you all talk about frozen elephant trunk, but why is it called frozen? If I tell you the answer, it will be like a wind tunnel, right? I want you to go and find out why is it called frozen elephant trunk, and
Okay.
let me know in the next class. I will not
Okay.
tell you. You do some research, you make an effort, and then you will remember it.
Okay.
Okay. Yeah. The other thing is TVAR has come as a major advancement in the management of these diseases, because surgical procedure is extensive and surgical procedure is associated with a lot of morbidity and mortality. So you must know the different types and what are the how to sort of evaluate a patient for TVAR. What are the measurements that you have to take? What is the landing zones? What are the landing zones, and what are the what are the types of grafts that you're going to use? And then again, if it's a hybrid procedure, whether you need a debranching procedure, or you put a chimney graft, or you put branch arterial grafts. These are things that you should also know, because nowadays it is becoming, as you rightly mentioned about an aortic team, it is a combined procedure done by both the surgeons and the cardiologists, and maybe interventional radiologists as well. So, and also the complications, you must know everything about complications of TVAR. So TVAR itself may be another topic for discussion, and how it is done, what are the pros and cons of TVAR, and then what are the different complications like endo leaks, and how to treat them. These are another things that you should talk about, because that may be asked as a
Okay.
major question for you. So chronic dissection and TVAR endovascular uh, management of aortic dissections should be done.
Okay.
And maybe before you come to the other thing, I'm also curious to know whether we have ever diagnosed intramural hematomas and ulcerations. You will have to probably sit with the radiologist or this thing and see whether these things are a known clinical entity in our scenario, because many of them are missed. I have never seen an aortic ulceration being treated in my career, because although we have done all sorts of aneurysms, right from the ascending aortic and this thing, arch and thoracoabdominal and descending thoracic aorta, but I've never come across a patient with aortic ulceration. Intramural hematoma may be there, but we have also had a couple of incomplete rupture at the isthmus. Again, you should know the pathophysiology. Why does it occur at the isthmus? What is the mechanism of injury?
Because it is static at that isthmus area. The other part of the aorta is free. So it will be static, and the other with collision, the other part of the aorta moves and it is static because of the shear stress.
It's called a shearing force injury. You must use the right terms. It's called a shearing force injury. The descending aorta at the isthmus is fixed to the posterior mediastinum, whereas the arch and the ascending aorta is mobile. So when there is a injury, there is an acceleration and deceleration process that takes place, and there is a shearing that occurs at the moving and the fixed part. And that is why it is commonly seen at the isthmus, that is just distal to the origin of the subclavian artery. And invariably, many a time, most of the time, it causes just an intimal rupture, and then there is a very, very intramural hematoma around it, and then slowly that expands. It may form a saccular aneurysm, and many often these are nowadays, as you rightly said, are treated by TVAR rather than surgical management. If you can get a proper lendic zone, the only thing is that you have to be very careful in assessing whether the left subclavian artery can be spared or it has to be included in your stent graft.
Okay.
Those are things that decision making, measurement, and then the conduct of the procedure has to be planned. Okay.
Okay.
Of course, the other areas of the aorta can also be involved in a trauma, blunt trauma. That is usually at the origin of the renal vessels, and also at the celiac, between the L1, around the L1 area, so where all the visceral vessels are taking origin. So that is another common area where you get aortic rupture.
Okay.
And mesenteric ischemia is a major problem in such cases.
Okay.
I wish you had involved Varun or any member from his team in this class, because they are the people who are doing aortic surgery in our institution, and it would have been nice to know our own statistics, our own experience, and what we have seen, and how do we decide whether we are going to do a endovascular repair or a surgical repair or a hybrid repair. It would have been nice if we had inputs from them. You didn't call them?
Varun sir is not there, sir, so I didn't call him. He's out of station.
You could have talked to Julius. You could have talked to the other fellows, Rohan or Siddhant, to take part in these things. You know,
Yes.
it is always nice to get an opinion from the people who are actively involved in management of these cases. My experience is almost 20 years old, so I don't do this anymore. So in the first 20 years of my career, I did a lot of things, and then the next 20 years, I have not been doing aortic surgery anymore. So my knowledge may be slightly outdated. So it is always better to see what is the present trend that is going on. Yeah.
Okay.
Okay. Anybody wants to make any comments? As usual, everybody is dead silent. Nobody wants to take part unless you talk, unless you bring in questions, unless you have questions.